So I do want to talk to you about maternal morbidity and mortality, and want to let you know I will throughout refer to women to describe pregnant individuals, but I do recognize that there are transgender and non-binary individuals who get pregnant and have babies, and for whom all of this applies. Earlier, Dr. Howell, I think it was, had described maternal morbidity and mortality as the tip of an iceberg, or at least the mortality as a tip of a morbidity iceberg. And I want to put to you that it's the tip of several icebergs, actually. I'm going to use as an example the connection between preeclampsia, which is one of the primary causes of maternal morbidity, and its connection to lifelong cardiovascular disease, which is, of course, the primary cause of mortality among women. And I will depict it a bit for you here with this graph. If you take the x-axis here to be the life course, a woman's life, and the y-axis to be her vascular risk during that life, and consider this black line here, the threshold for clinical detection of vascular risk. A woman who goes along and has two normotensive pregnancies, you see right here, experiences the normal cardiovascular adaptations and physiologic stress of a pregnancy, but is below the level of clinical detection until perhaps late middle age, she might develop chronic hypertension. Contrast this with the risk of a woman who develops preeclampsia in her two pregnancies. We see her vascular risk rise above the clinical detection threshold during those pregnancies, and then it goes underground again, only to resurface later as more and earlier cardiovascular risk. What we also understand increasingly is the lead up to that pregnancy complication is one that is an increasing risk over the life course of girls and young women. Now, I think of these pregnancy complications and maternal morbidities as the tip of an iceberg in several ways. So, first of all, there is this life course breadth, that there are events before pregnancy and after pregnancy that really tell us a lot about that maternal morbidity and mortality. But also that we have historical depth here, that we have this below the water is discontinuous healthcare, particularly for women on Medicaid. There are gaps in healthcare. There's inadequate healthcare. We're looking at issues of intergenerational poverty, and I think many of us would argue we're looking at the legacy of enslavement and settler colonialism. Some of this also reflects our history as scientists. For centuries, really, women's health was synonymous with reproductive health, and it was largely the domain of OBGYNs. Meanwhile, cardiovascular health, which we thought of as a men's disease for a long time, mistakenly, of course, was the province of cardiologists and internists. It was only when we really began to break down these silos that we appreciated that factors like gestational diabetes, low birth weight, preterm delivery, and preeclampsia each presage about a doubling of the risk of cardiovascular disease death, of course, the most common cause of mortality among women. Because of these disciplinary silos, we completely missed the obvious, and we lost decades that we might otherwise have gained in preventing disease. It reminds me of the old cartoon of Rich Uncle Moneybags, the Monopoly guy, who says, "I'm looking for my quarter I dropped." He's under the streetlight. "Did you drop it here?" says the police officer. "No, I dropped it 2 blocks down the street." "Then why are you looking for it here?" "Because the light is better." Huh? This is known as the streetlight effect. I first learned about the streetlight effect as like losing your keys under the light, but it works equally well for a quarter, where we've got some people looking at reproductive health while other scientists are looking at cardiovascular health, looking away from each other. You could replace cardiovascular health with mental health, with cognitive function, with infectious disease, you name it. And as we think about maternal morbidity and mortality, I want us to be careful not to leave that in the domain of the OBGYNs separate from everything else. That old way of looking at things reflects what Nanette Wenger so aptly coined as bikini medicine, the tendency of medicine to concentrate on the breasts and reproductive organs while essentially ignoring the rest of the woman. Bikini medicine, we all appreciate now, is not the same thing as women's health. And I was greatly cheered to see the statement in the Trans NIH strategic plan that the health of women encompasses all diseases and conditions that affect a woman from head to toe, and recognizes that individual level biological factors, interact with numerous influences across a woman's life course. So this is wonderful. It includes, all diseases and conditions. It includes the individual nested within society, and it looks across a life course. The question is, how do we translate that into research and into practice? While we've been gaining those insights, we've been losing ground in maternal mortality, as I couldn't hear the earlier presentations, but I'm sure they presented. We've had increases in pregnancy-related mortality in the US over the past couple of decades. Sorry, I have to move this banner out of the way. There we go. Maternal mortality risk accrues across the life course, particularly for minoritized women, Black and Indigenous women. And what you can see in this graph is pregnancy-related deaths per 100,000 live births. We have gaps here at about age 20. They're about twofold for minoritized groups compared to white women. We have gulfs here out at age 30 and above, where that gap, that racial disparity grows to 4, even 5-fold. What this argues is that we really need this life course approach to maternal morbidity and mortality, and that these factors are socially determined and inequitably distributed. This is not genes causing this. This is environment. This is a toxic environment. Each of the leading causes of maternal death is 2 to 5 times more common for non-Hispanic Black mothers compared with non-Hispanic white mothers. If this looks familiar to you, it should. Those who've been in the field for a while will remember Arlene Geronimus's work looking at percentage of very low birth weight deliveries among Black and white mothers in Chicago. And you see a very similar pattern with increasing age. And she coined the term the weathering hypothesis, that the effects of social inequality on health compound with age, leading to growing gaps in health status through young and middle adulthood. Further adding that the stressors that impact people of color are chronic and repeated through their whole life course. And again, I would say we need to figure out what is going on before this age and what is going on throughout the reproductive life course, and what does this imply for life after the reproductive lifespan. These social determinants of health are really key. One of them that we don't talk about often is the impact of violence on the health of young women and maternal mortality and morbidity. I point you to a really wonderful publication by Samia Nursi, Janine Clayton, Jackie Campbell, and Phyllis Sharps, published 2 years ago. They say to have a full picture of MMM, it's crucial to understand all the factors that contribute to the overall health of women. Conspicuously missing, they point out, is violence against women. It's very prevalent. In her lifetime, a woman has an 18% chance of experiencing sexual violence, 31% physical violence, and 36% psychological violence. Physical abuse itself, only physical abuse, affects 6% of women in pregnancy or in the year before pregnancy. It's really quite prevalent. And we know from lots of research, there are dose-response associations of abuse at any point in the lifetime, childhood, before pregnancy, during pregnancy, after, with physical, mental, and behavioral health risks, including many of the underlying contributors to maternal morbidity and mortality. Oh, sorry. It was mentioned earlier that homicide, suicide, and drug overdose while pregnant or within a year of pregnancy, while they count as pregnancy-associated deaths by the CDC, they don't count as pregnancy-related deaths, which means they're missing entirely from MMM statistics. So not only do we miss the deaths due to homicide, suicide, and drug overdose, but we end up underestimating the impact of violence throughout the life course on the factors that lead to maternal morbidity and mortality. And many of these are mounting risks of chronic disease before the pregnancy. You see here, since 2005, about a 40% increase in the risk of having a chronic condition before pregnancy. It's even greater increase, so the absolute numbers are smaller, for the risk of multiple conditions. What we've seen are marked increases in chronic hypertension, asthma, pre-pregnancy diabetes, and substance use disorders, especially in low-income communities, rural communities, and among women with Medicaid insurance. At least half of the pregnancy-related deaths in the United States are due to cardiovascular-related morbidity. You've got your other cardiovascular conditions, your cardiomyopathies, thrombotic pulmonary or other embolism, your strokes, and your hypertensive disorders of pregnancy, all contributing to maternal morbidity and mortality. If we were to put homicide in here, it would probably fall in the range of sort of 3 to 6 per 100,000 women. I think Maeve Wallace will probably talk about that later. That's about a twofold higher increased risk of homicide during pregnancy than at other times in a woman's life. But I will point out that lots of this cardiovascular risk is probably preventable. And that this leads us to a new understanding of health, that reproductive health and cardiovascular health are not separate systems. And I think the omics revolution will only reinforce that. And it's not just cardiovascular health. These are some data we have from recently published from the Nurses Health Study 2, looking at hazard ratios for the risk of cause-specific mortality before age 70, according to occurrence of hypertensive disorders of pregnancy. And so you see what the expected increase in the risk of CVD, but what you also see, and what frankly surprised us, is increased risk of infectious disease, respiratory disease, nervous system disease, and ill-defined diseases. This suggests that there are an awful lot of silos we could be breaking down. For better or worse, there we go. NIH is made up of 27 institutes and centers, each of which has its own specific research agenda focused on particular diseases or body systems. We've already talked about the insight that you get from sort of the collaboration between NICHD and NHLBI and breaking down those silos. I would argue to you that there is the potential for really innovative, insightful research that would help the health of women during pregnancy, throughout their lives, and also improve our understanding of men's health by breaking down some of these silos. This can either be a sieve with a lot of lost opportunity, or it can be a really powerful web that breaks down silos to come up with new insights. And the question, I think, is, does our siloed strategy mean we miss important insights for women's health? So what maternal morbidity and mortality teach us about NIH strategy, and particularly thinking of those conditions as the tip of a life course iceberg? It really argues we do need this cross-disciplinary work. We need it across the institutes at NIH. We need it across agencies, with the CDC, the FDA, PCORI, you name it. We need a life course approach. I would suggest that all RFAs and proposals should at least consider events, should frame their question with about maternal morbidity and mortality with respect to events before and after the pregnancy or the period under study. I think we need to prioritize research on the health of girls and women, including reproductive health, across all the ICs. I think we're all on the same page about that. We want to promote translation. All proposals should include not just plans for dissemination, but actually at least some thoughts about how it might be translated, that kind of vision. And I think scientists need more training in translation, especially community-based research, perhaps even a new K directed that way, something to help people train into translation. We also need to keep moving beyond bikini medicine. I think the ORWH has done an excellent job of moving us away from bikini medicine, but I think the peril is still clearly there. Women's health itself merits more investment, much more investment in cross-disciplinary funding and coordination. We need a coordinating body that has a large purse, some power, and the mandate to ensure a holistic, translated women's health research agenda. And I would argue that's a larger role for ORWH, if not an actual new Institute of Women's Health. And then finally, we really just need to see maternal health as only one part of larger women's health agenda. Both maternal health will fail and women's health agenda will fail if we revert to bikini medicine. And I leave it there, and thank you very much.